Welcome everyone to my 9-month progress report of the PhD studies. My topic is about the effect of anterior cruciate ligament injuries on the knee joint. I'm Robert Jonge from Uzsoki Street Hospital. My vision is to understand the nature of sports injuries and provide a better care and life quality for knee-injured patients. And we could achieve this by resolving disagreements and controversies of anterior cruciate ligament injury and therapy. I have 2 ongoing projects right now. First one is comparing conservative treatment and reconstruction, and the second one is adding an extra procedure to the reconstruction. So first one, conservative versus operative treatment of isolated injuries. Let's get into the middle of it. We are at the manuscript writing phase right now. We have this table doesn't show the work we have put in the last 3 months. We are at the discussion writing, just finishing it, so only a few steps before sending it out to the internal review. And we are aiming to publish it at the British Journal of Sports Medicine, which is a D1 journal with more than 12 impact factors. A little background: rupture of the ACL leads to instability, which is a risk factor of early-onset osteoarthritis. In the US, there is more than 130,000 rupture reconstructed a year, and the gold standard treatment is surgical reconstruction. However, with a good rehabilitative treatment, dynamic stability can be effectively regained, as well as it eliminates the risk of surgical complications. Despite this is one of the most studied topics in orthopedics, we still do not understand which option could be better, and this is our aim to find this out. We have investigated isolated ACL ruptured patients who were reconstructed, comparing them to the conservatively treated ones and focusing on radiological and functional signs. Our hypothesis was that reconstruction has a better outcome compared to conservative treatment. We had more than 13,000 articles, of which only 5 made it to our review. So let's talk about results. First one is radiological signs of osteoarthritis. There are clear signs on the X-ray of which we can tell if a knee is normal or abnormal, and there is a clear cutoff value between the 2 groups. So this is the forest plots of the first results. On the pool odds ratio, we can see that there is almost 2 times higher odds to have a normal knee with conservative treatment compared to reconstruction, but this is not a significant difference. Electrometry measures the translation of the tibia, comparing the injured and the normal extremity. Here we can see that the pooled mean difference shows that there is less laxity in the reconstructed knee joint compared to the conservatively treated one, and this is a significant difference in here. The Lism score is a patient-reported subjective outcome measured on a scale from 0 to 100 that consists of 8 items that measures symptoms and activity. Here we can see that the mean difference of the 2 groups is 2.88. But this is not a significant improvement in the reconstructed group. So the summary of my result: radiological signs show no significant difference, but it favors the conservative treatment. Electrometry has a significantly better stability for the reconstructed groups. However, laxity lower than 3 millimeters is considered normal, so clinically it is actually considered as normal laxity. And the Lism score, there is no significant difference as well, and not even 3 points difference on a scale to 100 is nor mathematically neither clinically meaningful. This is a systematic review about the outcomes. Because of the high variety of the outcomes and the poor data reporting, we weren't able to analyze all of them mathematically, only the green ones. The other ones will be at our systematic review discussion. Here we can see that only the IKDC examination score favors the reconstruction from those that weren't analyzed. All of the others has no significant difference between the two treatment groups. So the strengths of our study that this is the most comprehensive literature search available until now, and our findings and suggestions could serve as a recommendation for study designs and may affect the guidelines in the future. Of course, there are limitations. We had only a few studies with really different outcomes. There were poor data reporting, and only 2 RCTs were included. And the ACL reconstruction techniques were heterogeneous in the studies. So the conclusion is that conservative treatment could be also an option for the isolated ACL injured patients. We implicate it as we should consider conservative treatment as a primary option for this subgroup of ACL injured patients. And for research, there are more RCTs needed with standardized research protocols and standardized outcome reporting. Also, studies with more specific populations are required. So my second topic, that adding an extra procedure to the reconstruction of the ACL. As I said, ACL injury is one of the most common knee injuries, and the gold standard treatment is reconstruction with good to excellent outcomes. However, 25% of patients have residual rotatory instability, which is associated with poorer outcomes. And the anterior extra-articular procedures is considered as an additional process to reduce the rotatory laxity of the knee, and our aim is to find out if reconstruction with these procedures are superior to reconstruction alone. And this is our clinical question as well. We are investigating patients attending ACL reconstruction with the anterior extra-articular procedures, comparing them to reconstruction alone, focusing on knee stability, functional outcome, graft failure, and revision rate. Revision rate is a really important outcome because we don't want to spend a lot of money on operating a patient that will fail in a short time. Our hypothesis is that reconstruction with the extra-articular procedures decrease rotatory instability, leads to better outcomes, and lowers the rate of revision compared to reconstruction alone. And basically, this is the goals of the clinical implication as well. We had more than 6,000 potential articles, of which almost 2,500 made it to the title abstract selection, and we are at the title abstract selection phase of this project. So these are my 2 topics. We are planning to submit the first one in June this year, and hope we can submit the second one at the fall of this year. Thank you very much for your attention. The only thing that doesn't change at the last 6 months is my motto that all the time I set the bar low is for limbo. Thank you very much.
Thank you for your presentation. My question would be, for which subgroup would you recommend the conservative therapy? For example, for us, would you recommend it for young people?
Well, actually, if you have an isolated ACL rupture and you are not overweight, you don't have any comorbidities, you are not an elite athlete, then based on this data that we have in here, I would say yes, you should start with a conservative treatment. And if we start with a conservative treatment, then there is always the option to change strategy and have a delayed surgery if there are any other injuries.
Thank you very much.
Beautiful presentation, thank you. Connectively with the question before, if we start conservative therapy, can you say for how long can we wait until it gets better, or until we do the delayed surgery?
Well, it's based on the function, based on how well you can regain the dynamic stability of the knee, and based on the concomitant injuries. If you get a meniscal injury, for example, in the future, or a lateral ligament injury, or any other ligament injury, then I would suggest to do the delayed surgery.
I would like to ask you, what was the reason to choose the Lisholm score for evaluate your results, and not to choose the other clinical score system?
Well, I will go to my systematic review table. Actually, IKDC evaluation score would be good as well, maybe better than Lisholm score, but only one study reported this. Lisholm score were mentioned in more studies. Also, Lisholm score is a reliable score for isolated or a few structural injuries in the knee. With the number of injuries in the knee, then the Lisholm score is not as reliable as for an isolated injury, and this is a widely used score system, and with an isolated injury, this is really reliable. So that's why we use it and we rely on it.